I am Dr. John Carroll, a gastroenterologist at MedStar Georgetown University Hospital. The patients I see are oftentimes those with problematic acid reflux and or those who developed damage to the esophagus from reflux. And that would be either early esophageal cancer or precancerous changes. I'll also see patients who may feel well and outside scans them show unexplained cysts and masses in the pancreas and the upper GI tract, and we'll look at those with endoscopic ultrasound. I'll additionally see patients with regular digestive pain and symptoms as well. No one should really develop esophageal cancer any longer. If they have heartburn symptoms and if they develop Barrett's esophagus, we detect it early and we follow them. If they're going to progress to early cancer changes, we can now pick it up endoscopically and eliminate it and save them the need for surgery and developing invasive cancer. The challenge is that about 40% of patients who have Barrett's and develop cancerous changes have no symptoms at all, and that's the real challenge in this. The tragedy is we'll see patients in their 60s or 70s with advanced esophageal cancer, and when you speak to them, they'll discuss having had heartburn symptoms since they were in the 20s, and they took Tums all the time. And the tragedy is they either never saw a doctor for it or they weren't referred for endoscopy, and so when they developed this precancerous Barrett's changes, they were unaware of it. But if we can pick it up in patients in their 40s and early 50s and follow the Barrett's along, if they are going to progress to early cancer, if we stay on top, we can pick it up early and cure it that way. My philosophy of care would be shared decision-making, in the sense that we can provide the patient with the data on what we know about the disease process, the symptom pattern, what the natural course might be, and then come to a decision with them in terms of whether medication should be started, whether procedures should be done, a scan ordered, and also individualize it based on their age, different medical factors. It really isn't a cookie cutter approach. I think it's sharing the decision with the patient, letting them know the options, and coming to an agreement on what's best for them. The most obviously rewarding, gratifying patients are the cases where they have an early esophageal cancer or advanced precancerous damage to the esophagus who would be on the way to developing invasive cancer requiring a larger surgery, and we can treat them endoscopically and reverse all that. That's certainly very gratifying to see, and you feel very happy for the patients and their families. I think someone should choose MedStar Georgetown really because of the people and the culture. You know, I came here 30 years ago from Chicago for an internship, and I remember when I first began being struck by just the people and the culture here, and that hasn't changed in 30 years. We'll have patients who come in for procedures and they finish up and they're in the post-anesthesia area. It's not uncommon where they'll say, this was just a good experience. And I think they mean just the people, from the check-in to the nurses to the discharge. And that's a not uncommon comment. And it's kind of what I feel on a daily basis. And so that's a really special part of Georgetown. So acid reflux is where the stomach acid that should be contained in the stomach splashes back up in the esophagus where it shouldn't be and is hitting esophageal cells which are not made to have acid exposed to them. And this can happen either from an anatomic defect or hernia where the stomach and esophagus meet, that's a common cause, or for many people, part of the normal stomach anatomy, there's a certain degree of natural acid reflux. It becomes a problem when the degree of reflux becomes excessive enough where it begins to cause symptoms. Acid reflux and GERD are sort of synonymous terms, but the difference is severity. And again, almost every person has some degree of reflux, but GERD stands for gastroesophageal reflux disease. And so once it becomes more pathologic, that's when we sort of think of GERD. And that could be either severity of symptoms, where the symptoms become problematic, requiring dietary changes of medications, or it's caused damage to the esophagus itself. So acid reflux can be a normal physiologic condition. GERD is when it becomes a problem medically. So it's a clinical diagnosis, meaning how the person responds to treatment gives us the best information. And the most helpful way to diagnose GERD is to put the person on acid suppression medication or have them make dietary changes that lower the acidity. And if that improves their symptoms, that tells us it's GERD and reflux. There are tests where we can go in and actually measure the pH in the esophagus. It's called the esophageal pH test. That's fairly involved and can be a little bit uncomfortable for patients. And so it's done in a real minority of cases. So for the vast majority of people, if the symptoms are suggestive of reflux, through either dietary modifications or medications that lower the acidity, and then the patient's response, that can confirm the reflux diagnosis. So the answer to that would depend on both severity of symptoms and age of the patient. In terms of severity, if the patient has mild symptoms and they're improved by making dietary changes or medications, then that confirms the reflux diagnosis, and it's fine to continue managing like that. If the person wanted to be off medications or wanted more definitive treatment, then it'd be important to see a gastroenterologist, and surgery can be done. Either thoracic or general surgeons can do surgery to tighten the stomach valve, and that can cure it. The other indication to see a doctor would be because of age. And if someone is under 45 with reflux symptoms, there really isn't a concern for any damage to the esophagus. But in a small percentage of people, over time, it can lead to precancerous changes. But you want to wait till 45, 50 to check for that. And so if someone has well-controlled symptoms, they would really not need endoscopy look until they reach the age of 45 or 50. Yeah, it can occur in infants and teens and 20s and 30s. And one of the interesting things is when it begins, and that can be in your 20s, 30s, 40s, it tends to be an ongoing thing. It's once the body begins to develop some abnormal reflux patterns, whether it's because of a large hernia or whether the stomach valve just relaxes more than it should, that tends not to resolve on its own. Losing weight will improve things, and there are some people where weight loss alone may eliminate the reflux, but for the majority of people, it is to some degree an ongoing symptom pattern going forward. And that varies. There are some patients with very severe symptoms where they may need medication control almost indefinitely to remain symptom-free. Others that can have a more variable approach where they can make dietary adjustments and feel well for months and months and months, and then they may get a recurrence. So there's a really wide spectrum of the severity of the disease. Barrett's esophagus is when the esophageal cells, in response to being bathed with stomach acid, form a protective change to better withstand that acid injury. It's almost like forming a callus. And one of the many unknowns about Barrett's esophagus is it only happens about 10% of people with chronic reflux. For the majority of people with uncomfortable acid reflux, when you look in the esophagus, it actually looks normal. And about 10 to 50% over time, when the esophageal cells are bathed with acid, they will form this protective change to better withstand the acid injury. And they take on cell linings similar to the stomach and the intestines. And that's called Barrett's esophagus. The significance is, like almost any cell in the body, once they change, they're more unstable and they can change further and become cancerous. It's a low risk of Barrett's becoming cancer, but when it occurs, it's certainly a very challenging cancer. There aren't any symptoms for Barrett's per se other than acid reflux. When we see people in the office, it's really alarming at how unreliable our symptoms are for what's really happening inside the esophagus. There are other conditions, say the gallbladder, for instance, where if the gallbladder is inflamed, the symptoms are very straightforward and there's not much variation. It's a very kind of open and shut case. But when problematic acid hits the esophagus, people can have no symptoms. They can have typical indigestion, heartburn. Their symptoms may just be trouble swallowing. For other people, it can go up and bypass the typical heartburn symptoms and manifest just in the throat. And their symptoms may be cough, hoarseness, a sense that something stuck there. That's called laryngeal pharyngeal reflux, the LPR symptoms. So Barrett's itself aren't any specific symptoms other than the umbrella of having occurred in acid reflux. So for Barrett's, it's really been a game changer in the last 15 years or so. Years ago, and when I was training, there was no technology to eliminate the Barrett's and the precancerous change in the esophagus. So we would follow people, and we would follow people with Barrett's. And in the patients with Barrett's that do get cancer, their cells take on changes over time where they develop more advanced precancer changes and then become cancerous. And so the approach had been to follow people with periodic endoscopies, and at the first sign they were taking on more advanced precancerous changes, they would then go to surgery, what's called an esophagectomy. And it's a major operation where the lower part of the esophagus is removed and the stomach's pulled up. It's a very big operation. It's still done for esophageal cancer patients. The new endoscopic technology became available in the last 10 or 15 years or so, and we now have the ability to burn off all the precancer esophageal cells, the Barrett cells, and if the person is under good acid control, healthy normal cells grow in. And at this point, if we pick up Barrett's early cancerous changes, we can, with near 100% efficacy, reverse it back to normal and prevent the patient from developing invasive cancer or needing surgery. So the Barrett's itself doesn't provide any symptoms other than typical heartburn. In the patients that don't realize they have Barrett's and it goes on to progress to cancer, it only becomes evident to them once they develop an advanced cancer that is constricted the esophagus and food's getting stuck. And so the tragedy is that almost half the patients with esophageal cancer who had Barrett's were unaware that they had it. And so the difficulty is in patients that didn't have an endoscopy, didn't have Barrett's diagnosed, will be unaware they have until they develop an advanced obstructing cancer. And so the key and the goal is to pick up patients with routine heartburn symptoms at a younger age, to pick the Barrett's earlier to prevent the cancer from happening. So there are two types of esophageal cancer. There's a less common called squamous cell cancer that hits the top of the esophagus. And the big risk factors for that are smoking and excessive alcohol. But the other more prevalent esophageal cancer is called adenocarcinoma, which we've been talking about. And the risk factors for that are acid reflux. Once you get reflux symptoms, you can't just make them go away. It would be a matter of taking medications, doing dietary changes, or having surgery to correct the GE junction. But the most important thing is, if you're of a certain age, at 45, 50, have an endoscopy done to pick up Barrett's esophagus. Because if we pick up patients with Barrett's esophagus early, we should be able to prevent esophageal cancer in almost everyone. So that's the key. One of the many things about Barrett's esophagus and reflux and esophageal cancer remains unknown is why certain people develop it and others don't. And the studies have shown consistently that white males, overweight, are the highest risk for developing Barrett's and esophageal cancer. So if you take all the patients with acid reflux, it's the white males, overweight, that are the highest risk of developing Barrett's. And they're also the highest risk of going on to develop cancer. So people with, women can get Barrett's, other ethnicities can get Barrett's, but they're also less likely to get the Barrett's and less likely to progress to cancer. Once patients come into us, and in our gastroenterology, we're oftentimes the frontline entry point for patients with heartburn symptoms, Barrett's, early cancer changes. We have just a wonderful team of oncologists, thoracic surgeons, radiation oncologists, and we work so closely. And so once they're in the system, there's such tight collaboration with all of us. And if the person does need surgical referral, if the person does have an advanced cancer, needs oncology as well, we do, I think, an excellent job of coordinating that care, keeping the care very tight and cohesive, and taking everything from there.